Dear students, I'll just show a operative step, but a very important operative step which we very commonly come across. Just have a look. See that it's a groin area. Inguinal ligament is here, conjoint tendon is here, external oblique is here. You can see that with the typical indirect inguinal hernia sac. Typical inguinal hernia sac. So usually either spinal anesthesia or general anesthesia or local anesthesia. In Western countries, commonest anesthesia used with the local anesthesia, otherwise general anesthesia. In other country like us in India, we commonly use spinal anesthesia and often local anesthesia. And children always general anesthesia. And cleaning and draping, incision is just above the inguinal ligament medial 2/3, 1.25 cm above. Skin, 2 layers of superficial fascia, camper and scarpas incised. External oblique is very shining, incise it and cut up to the superficial ring, but take care of the iliac not to injure it. Then to hold the external oblique upper leaf, lower leaf with the artery forceps, reflect it. Above you can see the conjoint tendon after reflecting. Below you can see the inguinal ligament, very shiny, yellowish, golden colored ligament is inguinal ligament, Popwart's ligament, otherwise it is called as. And once you identify that, you can see the ilioinguinal nerve, which is in the inguinal canal, not inside the cord. Cremasteric muscle has to be opened up, then you can see the cord with the sac. Indirect inguinal hernia sac is anterolateral. It is got a fundus body neck. It is a pearly white in color. So start the dissection from the fundus, dissect up to the body and neck. Neck should be identified by the extraperoneal fat and narrowing the area, and it is lateral to the inferior epigastric artery pulsation. Inferior epigastric vessel should be identified always in open inguinal hernia surgery. That is the Lichtenstein's hernia mesh repair. And inguinal hernial sac is lateral, direct hernial sac is medial. Direct hernial sac is always from the posterior through the inguinal canal it comes. It has got a wide neck. Direct sac is usually not opened. Indirect sac always should be opened. It should be opened in the fundus. Then once you open the sac, after proper dissection, you put your finger and reduce the content to confirm that. Then always twist the sac. Dissection should be high dissection above the internal ring or deep ring. Deep ring is opening in the transversal fascia, whereas a superficial ring is opening in the external oblique aponeurosis, otherwise called the external ring. So above the internal ring or deep ring, you should dissect. High dissection is very, very important. Then I twist the sac at the neck, then transfix and ligate. Why you are twisting is because the content should not come through that while you are transfixing. You may take the bite from the bowel. Then transfix and ligate it through Vicryl polygalactin 21020 number, and distal part you remove it, is called herniotomy. Then place a mesh, adequate sized mesh, usually 15 into 7.5 centimeter mesh is used, and below it is the suture to the inguinal ligament using polypropylene suture material 10 or 20, and above to the conjoint tendon the interrupted sutures, and laterally should be cut, and to encircle the cord, two leaves, upper lower 1/3, upper 2/3, then cover it and again fix it laterally, medially and above. Medially should overlap 2 cm over the pubic tubercle, above 4 cm to the conjoint tendon, laterally up to the anterior superior spine for 6, 2, 4, 6, 2, 4, 6. Don't forget this number, 2 cm, 4 cm, 6 cm. Then place the cord and ilioinguinal nerve. Then close the external oblique, subcutaneous and skin, either stapler or intersuture or subcuticular monocrystal suture. Then place a dressing. You can do it under local, commonly GA or spinal. In Western countries, European countries, local is a common daycare surgery procedure. In our country, commonly we do it under spinal. Local is definitely acceptable method. In a large hernia, it may be irreducible, it may be difficult. So it is called Lichtenstein's open, onlay, tension-free mesh repair. These wordings are very, very important. Spelling Lichtenstein is also very, very important. Remember. So anesthesia, remember, incision, dissection of the sac, identification of the sac, I said, safeguarding nerves, ilioinguinal nerve, hypogastric nerve, genital branch of genitofemoral. There are 3 nerves: ilioinguinal, iliohypogastric, genital branch of genitofemoral nerve. Herniotomy, selection of the right-sided mesh, I said, placing and fixing closure. All these steps I already explained. You take a note of it. It's usually asked as a operative surgery question in Viva. In Oxy they will ask. In theory they may ask steps of the hernia surgery, because very commonly done procedure worldwide. Commonest surgery actually done worldwide by general surgeons is the hernia surgery. So Lichtenstein's open hernia mesh repair is very commonly done. So you have to know all these steps. So one of the steps is dissection of the indirect hernial sac We'll never, usually won't open the direct sac unless it's irreducible, descending, becoming complete. Rarely our direct sac may become complete, whereas indirect sac commonly becomes complete. So that is the point you have to remember. So answer the MCQ. The most common organ that herniates through the Margogni hernia is liver, A, spleen, stomach, transverse colon. So put the right answer in the comment box, students. I'll get back to you. So another MCQ is canal of neck is A, inguinal canal in females, femoral canal in females, obturator canal in females, pygienal canal in females. Find out the right answer. I put it in the comment box. I'll get back to you. So students, I hope you have understood this operative step of inguinal hernia surgery, open method Lichtenstein's herniaplasty very well. It's commonly asked viva and operative surgery short note may be asked. So I hope you have understood this lecture very well. Thank you so much. So students, go through my SRB's clinical methods in surgery, which has got a video lectures of each topic. So many topics are covered. Every topic as far as CBM syllabus is covered. How to examine the patient. Swelling, ulcer, arterial disease, venous disease, thyroid, breast lump, mass abdomen, briefly orthopedic, every system, whatever your required thing, everything is covered. There is a video of how to examine of each topic, and principles of examination is good, and differential diagnosis in the table format is given, and briefly investigation. Suppose treatment is not a topic will be covered in a clinical method examination, remember, and many photos of the most of the conditions with the illustration. Photos will tell the clear idea about for the students how exactly condition looks like. So covers everything with the beautiful photos, and it also gives the instruments, specimens, then operative surgery briefly. Everything is covered. Small images also it is covered. So it is more than sufficient for all undergraduate, postgraduates of any system to learn very basic required thing for the surgical field is clinical methods. So please go through that and purchase that and make use of it. My SRB manual of surgery is very popular. It covers theoretical aspect, everything, principles, treatment in detail, briefly technical aspect, and with the photos, illustrations, quotations, all topics with the specialty, urology, cardiothoracic, neurosurgery, and operative surgery instruments. Again, it is covered in this book also. Every quotations, and you should worldwide also, actually including our country, everywhere. And please, you can make use of it. My operative surgery book, SRB's operative surgery atlas, that is a 2-volume book, covers in detail operative technique of surgery, all surgery, small surgery, major surgery, everything, with total around more than 10,000 illustrations and photos. It gives very good principles and technical, step-by-step technical aspect. Very useful for postgraduates. Not much useful for undergraduate, but it's a postgraduate book and consultant book and learner after MS. It gives everything. You can, before going to surgery, you can always read this book and memorize your steps and do the surgery properly. Every topic, general surgery, gastroenterology is covered in detail, step-by-step with illustrations. And my SRB's atlas of tissue approximation, small book atlas, 100 pages, how to do the suturing, tissue approximation, including laparoscope suturing with the video. It is covered. So any basic learners, suturing is very important surgical field as a skill actually. Dissection and suturing, so the two parts of the surgical skill. So that is also covered very well with videos. You can always go through that. And my website, please subscribe, all of you. Your daily lectures are there, live sessions are there. My DigiNower lecture through JP Publishers, around 220-hour lectures. Entire thing as for CBM is covered with the examination part, with all topics of CBME, ulcer to operative surgery, instruments, specimens, examination, specialties, basic, everything is covered. You can always purchase for 1 year and have a clear idea about the surgical topics, understand very well, and helpful for your exam, NEET, MCQs. Also, it is there both in manual and my lectures. So students, I hope you have understood this lecture very well. Thank you very much.